record. All right. So we will get started. So today's topic is gender identity and challenges within the intellectually and developmentally disabled population. And Dr. Kent and I will be leading this training. And again, please feel free to unmute and join the conversation with any questions or comments as we go through. I cannot see everybody on my screen, so if you're trying to motion that you have a question, I probably will not see you. So just unmute and jump right in.
I had a quick question. I'm sorry.
Sure.
I had to move my car, so I missed the part of you saying that it's going to be recorded and whatchamacallit, so we can watch it again if necessary.
Yes, if I'm going to be recording it, and if there's any need, we can share it for training purposes for anyone that would like to either rewatch it or if anyone that missed us. So absolutely, you can reach out to get the link for the recording if you'd like. You have Shirley's email based on getting the information, so you can reach out to Shirley and we can funnel it through her.
All right, thank you.
No problem. Thanks, Sean. Okay. So we're going to start with some terminology. Really to start this topic. Okay. We felt it was important to provide you with a bit of a word bank. For some people, some of these terms may be new, or you may have heard them and not truly know what they mean. And it's really important as we're going through this training. We will be using a lot of these terms throughout. So we wanted to kind of start from this place to ensure that everyone had a good understanding of what we were discussing. And obviously you can reference these at any point. So cisgender describes a person whose gender identity aligns in their traditional sense with the sex assigned to them at birth. So you're born male, you are male in your everyday life. Gender diverse. So this is an umbrella term which describes individuals with gender identities or expressions that vary from the expected developmental norms. So this includes people who may identify as multiple genders, as transgender with no gender at all. So again, this is an umbrella term that encompasses several different gender expressions. Gender dysphoria, it's a concept that's designated in the DSM-5 as clinically significant distress or impairment related to the strong desire to be of another gender. So this may include the desire to change their primary gender and or their secondary sex characteristics. Not all transgender or gender diverse people experience dysphoria. We are going to talk about this in a bit more detail for the gender dysphoria, but it's important to note that not all transgender or gender diverse people have a DSM-5 clinically significant diagnosis of gender dysphoria. Gender expression. So this is the outward manifestation of a person's gender. It may or may not reflect their inner gender identity based on traditional expectations. This incorporates how people express themselves, how they carry themselves, their dress, their accessories, their grooming, their voice or speech patterns, their conversational mannerisms, even physical characteristics. Gender identity is a person's inner sense of being a girl or woman, a boy or a man, or some combination of both, or something else, which can include having no gender at all. This may or may not correspond to the gender assigned at birth. Non-binary is a term used by some individuals whose gender identity is neither girl or woman nor boy or man. So again, choosing to have no identifiable gender. Sex and gender assigned at birth. So this is the traditional designation of a person as female, male, or intersex based on their anatomy. Sex and gender are often used interchangeably, but they are distinct entities. It's best to distinguish between sex, gender identity, and gender expression, and not to make assumptions about a person utilizing these characteristics. Sexual orientation describes the types of individuals toward whom a person has emotional, physical, or romantic attachments. Transgender is also another umbrella term, which describes individuals whose gender identity does not align in the traditional sense with the gender they were assigned at birth. It also may refer to a person whose gender identity is binary and not traditionally associated with that assigned at birth. Okay. So gender continuum is a term utilized in the field of gender identity. And this indicates that gender is on a spectrum. So, we see a lot of things as spectrums, autism spectrum disorder being one of them. And gender really is on a continuum, on a spectrum. Gender identity can be described as the private and subjective experience of one's own gender, of maleness, femaleness, neither or both. Therefore, it is diverse. Most of us know what's called as the binary model of a man or woman, boy or girl, but this does not fit many people's experience of themselves. We also can see in the population with gender identity and gender continuum that it may change. Jennifer even mentioned with Melissa that at times in recent months, Melissa has mentioned maybe using they or them pronouns rather than she or her. So there is that continuum even within this case as well. So the gender unicorn, I don't know if anyone has ever seen this image before, but it's a visual model to teach people with intellectual and developmental disabilities about gender. It goes through gender identity, gender expression, sex assigned at birth, the physical attraction and emotional attraction. And this really is a great visual for even children that are questioning or, are learning about gender identity and the gender continuum. With people with intellectual and developmental disabilities, as we will get into in this training, in this presentation, there are a lot of challenges in the population on top of a neurotypical person that is questioning their gender or their gender identity and expression. So this is an opportunity to provide a visual to the population and to show them there's a lot of different aspects that go into our gender. So our gender unicorn is a great resource. Gender variance is when there is a difference between the sex that someone was assigned at birth and their experienced gender. So for some, this variance can cause discomfort or stress, which is referred to as gender dysphoria, which I mentioned briefly, and we'll go into a little bit more detail in the next slide. According to research, gender identity clinics are seeing a significant increase in referrals. People are presenting at an earlier age, and the gender difference is reducing with higher proportions of those assigned female at birth accessing services than in the past. Gender variance exists everywhere. It's irrelevant of ethnicity, culture, or socioeconomic status, although it is more hidden in some societies, and we may encounter individuals who, due to culture or other aspects, may have more difficulty coming out as their authentic self. Having a gender identity that does not conform to assigned sex is not a mental disorder. So I had mentioned earlier that there is a DSM diagnosis, does not mean that anyone that does not have their gender identity conforming to their sex assigned at birth has a diagnosable mental illness or mental disorder. It's more related to the distress that situation and that change has brought to them. Trans individuals are frequently subjected to stigma, discrimination, rejection, and abuse, which also leads to some of that distress, which we will also talk about in more detail.
Right. Gender dysphoria, that term comes from DSM-5, but people may be familiar also with ICD, which is the international classification. And ICD-10 was classified as transsexualism, but in 11, they've adopted the term gender incongruence, which makes a little bit more sense. In DSM-5, the gender dysphoria refers to psychological distress that results from an incongruence between your assigned sex at birth and your gender identity, which makes sense and kind of follows up on what Elise was saying. And again, trans is simply an umbrella term which refers to all individuals who do not identify as cisgender man or cisgender woman. Cisgender describes a person whose identity is the same as that with which they were assigned at birth. Now, the next bullet point I think is hugely important. Not everyone who identifies as trans experiences dysphoria. There are plenty of people that are comfortable with it. They're working on it. So I think in the lay press, we need to make that very clear. And our job in the mental health field is to say, if somebody is uncertain about their identity, that's okay. It doesn't mean that they have a mental illness. Absolutely not. And gender variance, as Elise said, is not uncommon. Just want to throw one added thing that I didn't think I was going to say on this slide, but Elise kind of made me think of it. To put it politely, in this political climate, it's become a bit of a football, a little bit of a political football in terms of value systems. And I think, unfortunately, there's a lot more press about, hey, we don't want these bathrooms, or hey, don't tell me what my kid should be, or let's go back to the normal stuff. So I just think we have to be cognizant of what's going on in our world and in our culture over the last few years. I just think it's made it harder for individuals who are going through this, especially if they're ID or ASD and struggle with their executive processing of it all.
Absolutely. So discrimination, unfortunately, is a large part, and some of that does go against what would, go with what Dr. Kent was just saying as well in the current climate. So African-American transgender people fare worse than all others, according to the research. A large amount of people in the transgender community do live in extreme poverty. This could be due to bias and discrimination in the workplace, not being able to maintain employment due to their identification. Some research has given us some percentages. So within the trans community, 41% report attempting suicide. This is compared to 1.6% of the general population. Those numbers are huge. A lot of that in the research and in all that we know from the mental health field does be based on trauma and bullying and discrimination. And we have seen suicidal ideation in the case that we're talking about today, Melissa. And she is a young woman that has experienced that significantly. 55% indicate that they have lost their jobs due to bias. Again, impacting their socioeconomic status, impacting their ability to live comfortable lives in our communities. 51% have reported harassment or bullying in school. This again is also something that has been seen in the case today, but in a lot of individuals at 51% in the trans community. 61% of people in the trans community claim to be and have indicated to be victims of physical assault, and 64% have indicated to be victims of sexual assault. So it is very, very high numbers. This is not a small amount of a random discrimination or random bias, or a very small concern. When anyone that we're working with in the mental health field and in the IDD field are a member of the trans community, these are numbers that will directly affect them. We want to think about their culture, their socioeconomic status and ability to hold jobs. The suicide risk is incredibly high in the population. And then, of course, the impact of trauma, bullying, discrimination, and assault.
Hey, Elise, I just want to add that as far as the cultural part, I think we shouldn't give that short shrift.
Yep.
We just had this at another lecture we gave, and again, not an expert in the Asian culture of Flushing, but for some reason I've gotten a rash of referrals from there. And in terms of a couple of cases where there was gender issues, trying to explain it to the elders of the family was brutal. They just didn't get it, they didn't accept it, and there was so much shame involved and embarrassment in these young adults that I think it really made it so much harder for them to accept themselves and to move forward.
Absolutely. One thing that Melissa is very fortunate of within her experience is her parents' support, her mother and father's support, and unconditional love, and just wanting her to be safe and happy, and accepting her for her authentic self. So she is very lucky within her family in that regard. I know we've talked about her siblings, and that is a little bit of a different experience, but having her parents support her and helping her strive for her authentic self is very big. And like Dr. Kent said, it's not always the case in every culture. So to move a little bit into the specifics about intellectual and developmental disabilities and gender identity, I want to start with talking about some research. So there is research, but it's not often research that is attributing to the numbers that I just reviewed. It's more case study, case series. These are mostly involving young people with autism. So the research in the population definitely has some growth to occur. Because of this, there is no specific evidence base or guidelines to assist the professionals working in the field. So all of us here, there really is no specific guideline to apply to the IDD population for someone that is having some difficulty and identification of their gender. We know it exists, and a wide range of learning abilities are described in the literature, but again, there's this knowledge base that is missing. In line with general population, more people with an intellectual disability are presenting to gender clinics at this time, which is wonderful. The gender identity clinics are becoming more adapting to the educational needs and the learning needs of this population. I know that we have been working really hard, especially within this case, but in other cases as well, that we have in START to educate these gender identity clinics right here on Long Island so that they can support the population that we are seeing. Some of the literature does put forward a number of possible reasons for people with intellectual disabilities presenting with issues related to gender. They'll talk about it as a means of escape. They'll talk about it as perhaps from, a means of escape from life or from their disability. They talk about it in a realm of trying to control anger, a lack of fulfilling relationships, or conflicts arising from non-heterosexual orientation. So, while it's important to assess, gender identity in this population, we also have to remember that they are experiencing the same gender identity conflicts as the neurotypical population, and it's not always just to escape something. So again, the research has a bit to be desired. I know that in working not only in this field with START, but in previous positions as well, I worked in a residential school who had a young woman with mild intellectual disability and bipolar disorder, and she did present as trans. And as our team as her clinical team was supporting her in that transition and changing the pronouns and really working with her, she wanted to do the legal side of things and then work towards surgeries. We had a lot of difficulty with the psychiatrist at that time at the residential school, and them just thinking it was part of her disability and that it was not real, which caused a lot of challenges in us moving forward. So there's still a lot of education in regards to the IDD population that's needed in regards to them having a trans identity and accepting that. Cognitive ability does appear to influence how gender dysphoria presents. So we've talked about gender dysphoria a bit already, and that is that distress related to a change in their gender identity. So cognitive ability does appear to influence the significance of that, which does make sense. There are definitely individuals who have a higher level of need in regard to communication and processing that may not understand what is happening for them and the experience that they are going through. So their own feelings may cause them distress. Again, we're going to talk about trauma a bit, but bullying and discrimination may also play a role in that as well for someone that has the lower cognitive abilities. We also may see more behavioral presentations as opposed to declarations within this population. So we may not see them being very forthcoming and communicating as to, I am now, by going by she and her pronouns, the way we saw with Melissa. She does have a higher level of cognitive abilities than some of our other individuals that any of us may see, but we may just start seeing them change in their behavioral abilities in regards to their dress or how they want to wear their hair, exploring use of makeup or nail polish if they're going from male to female. And again, with dress and haircuts and things like that when going from female to male. So we may see it more in that behavioral visual presentation. It is unlikely to present in individuals who are nonverbal, according to the research, given that the criteria relies on the ability to express distress in relation to gender. So this goes along with gender dysphoria. So it may not be clear that there is a distressing aspect in regards to their gender when they're nonverbal. Again, just like we talked about with anyone with IDD, their behavioral health symptoms tell us something. So even with someone that has a lower ability for expressive communication, we may be able to learn how distressing or upsetting or stressful their gender identity changes may be for them, even if they are nonverbal, but it takes a lot more assessment. We do see the influence of developmental delays on views of gender roles, sexuality, with perhaps more rigidity in these areas and in these ideals. We do talk a bit more about sexuality in a few slides and sexual education. Low self-esteem and lack of self-concept is a very important and under-acknowledged issue, which is arguably worse in those with an intellectual disability. They may already have self-esteem concerns and needs due to their disabilities and their other aspects that having a gender identity concern and questioning their gender may just exacerbate that. So the individuals may also provide ideas about what gender is, what different genders look like. That may be confusing for them based on their cognitive abilities and their abilities to take in this information. So this also can impact their developing sense of self. We also see consistently at times a desire not to educate the IDD population on sexuality. And I know Dr. Ken is going to go into that in a couple of slides as well, which also can influence gender identity if they're not exposed to this information.
Well, following up on your slide, the research is a little better in autism than IDD. And for some reason, it's a little better in England. And I don't know why, but they seem to be doing more of that there. And the studies are leaning towards, again, autistic individuals having a higher rate of gender diversity than the mainstream population. Now, what I like about these newer studies, they're not case studies. They're not gender dysphoric people who came and sought care. They're what's called prevalence studies. And prevalence studies meaning what it says, what's prevalent in the community, not new cases, but at that time, what exists. And when they did a study like that of late, 5% of cisgender typical population had mental health symptoms. 24%, and I'm sorry, not mental health symptoms, gender diversity issues. In the autism population, 24% had that. So that's very significant. And it kind of brings up some important clinical issues because I think a lot of times it's not even asked in ID and ASD whether that exists, or as Elise was alluding to, a lot of the providers don't necessarily believe it. Now, in both, there's social interactions that are impacted. When you think about it, in autism, they're going to be misreading of social situations. And if somebody's having gender identity issues, that may also lead to uncertainty about how they're interacting with the opposite sex or the sex they think that they relate to. So you put the two together, and you're certainly going to have more likelihood for behavioral health symptoms. Now, there is an opposing viewpoint that if somebody with autism doesn't believe they fit in, they may try it on like another set of clothes. So while I do think we need to believe and to investigate on an individual basis, there is some understanding of that argument that the numbers could be a little artificially elevated by that sense of testing the waters. And I kind of liken that a little bit to borderline personality. When you have a young individual who's not real solid in their identity, they may go through a phase where they think they're bisexual or gay or gender identity issues. So it all has to be factored in. All righty. Now, I don't remember, was this your slide, my slide? Who was doing this one?
This is you, Dr. Kent.
This is me, okay. Those with an intellectual disability experiencing gender dysphoria obviously face a number of difficulties. The presentation, again, from nonverbal to minimally verbal, to having less insight, to not being able to explain exactly what's going on, preconceived expectations, which we'll get into later, of the providers. They may not see them at that level. They may think that they're more childlike, which is not necessarily true. Because one has an intellectual disability doesn't mean the body is more childlike.
Dr. Ken, I think that you are on the next slide, which that one is me, but the one that we're on right now of autism and transgender identity, that's the one that.
Oh, okay. Gotcha. All right. All right, so let me go to that. So less research available, but again, as I said before, there is definitely more mental health symptoms. Well, that shows that's good and flexible. I just started talking about a slide that's not mine. There you go.
Yeah. I'm like, wait a minute.
Nobody would have noticed if I didn't open my big mouth. There you go. So anyway, so what type of mental health symptoms are seen? Well, depression and anxiety, clearly, and it makes sense. Think about, as Elise was again referring to, self-esteem is going to be down. There's bullying. I'm sure if the studies were done with more specifics, PTSD would also pop up there as well. So they're elevated in trans individuals to begin with, but worse if they also have autism. Now, I personally think that it might even be higher than the research shows because they're not presenting it and they're not explaining that they have those symptoms. So while these numbers are impressively high, they in fact could be even higher. Age also has to be factored in because it goes up with age. And think about it, if you have someone uncertain about their sexual identity at age 6, 7, 8, it's not as stigmatizing as when the hormones are flowing and it's a 12 to 15-year-old in middle school and early high school who all of a sudden doesn't relate, is getting abused, and stands out like a sore thumb to their classmates. So we're going to see it definitely go up with age. And this last point, transitioning and dealing with it is delayed to, quote, fix autism. I'll give you a great example. I have this kid in my practice, and I've known for about 6, 7 years, and this has always been an issue. The identity was something they were uncomfortable with, always thought was more female and wanted to transition. Had some significant depression, anxiety, but I think fairly regulated on my medication regimen. Spoke with a therapist, and we got them to a specialty clinic in Brooklyn for transitioning. And the person gets on the phone with me and says, you know, interesting case. I think you need a little more time to fix the autism. And then we'll work on the transitioning. And I said, how exactly am I doing that? And why am I doing that? So I had to kind of teach this person who was a very advanced physician in other areas that depression and anxiety, yes, needed to be fixed because you can't cognitively make good decisions. But the fact that somebody has autism is not the reason we delay. It may make it longer because of cognitive issues. It may take it longer because of how the person expresses it and understands it. But there's very much a misconception sometimes in that field to fix them before they'll look at that issue.
Okay, so Dr. Kent started the slide for me on the fly, but we're going to dive a little bit deeper. As we're talking, Dr. Kent, I was like, wait a minute. So just a reminder of gender dysphoria. So we talked about this a few times so far. This is the DSM-5 classification of clinically significant distress or impairment. Not all transgender or gender diverse people experience this gender dysphoria. So just to remind you of that. Some individuals may not present in the classic or typical way or history of gender dysphoria, especially as we're talking about the IDD population. But this is the case for many people with or without a developmental disability. It can be very stressful. There can be a lot of challenges in regards to bias and discrimination and trauma, as we've mentioned already. Having preconceived expectations about what we want to hear leads those whom we see feel pressure to give a history rather than their history. So we want to ensure that we are open to that dialogue in regards to understanding their experience. There is a real risk that gender dysphoria goes unrecognized altogether in this group. Obviously, all of us work in the field of IDD, and we understand the behavioral health symptoms that are noted. And, is it because of their gender identity that they're experiencing some distress that may come out as aggression or suicidal ideation or in other ways? Or is it because of their autism and their ID and maybe some other mental health concerns that they have? In this case for Melissa, she has a diagnosis of PTSD, which is rare. We see a lot of individuals in START that should. So we are glad that she is, properly diagnosed with PTSD because it is appropriate. But there is always that question as kind of what is the underlying vulnerability that's leading to her distress, and is gender dysphoria one of those? Or although she's dealing with bullying and maybe some other aspects that are impacting her, is there gender dysphoria also there because of distress in regards to the gender identity? It's something that really needs to be assessed. Diagnostic overshadowing, which means that there is a single diagnosis driving the overall view. So that is always a possibility in this population of, everything is related to their autism, when in actuality, there are other things going on that could be supported and treated. And that does also exist here with gender dysphoria. In society, there's a tendency to infantilize people with an intellectual disability, even when they are adults. So we do need to recognize and challenge this when we see it. Dr. Kent's going to talk about some sexual education piece in a few slides, and that is really important. Like I said earlier, we hear a lot that, they have intellectual disabilities, so they're just children, or they're like a child, when they do experience the same thing as neurotypical adults. And it's just about how they process it at times or how they can understand it. Occasionally, individuals describing a clear trans identity can sometimes be described by others as confused. So that definitely comes up in this population as well as the neurotypical population. But we often get referrals to START about gender issues or gender challenges, kind of seeing it as a negative thing that needs to be fixed, when they may just be very clearly indicating that they are transgender or are exploring their gender identity. We also just need to be very careful not to interpret gender variance as confusion. Again, gender is experienced on a continuum, even in this population. The environment can impact individuals significantly. There may be practical limitations such as access to transportation or finances. Limited autonomy means that the individual are relying on others to have many of their needs met. So they may have a expressed desire for exploring their gender identity, against that continuum, but be unable to buy the clothes that they want to wear due to not being able to get to the stores or not having the finances to do so. So again, we also want to be very in tune to the clues that they may be giving us.
Hey, can I add one quick thing?
Of course.
Yeah, I'm not stealing a slide. I had a patient last night that made me realize that I left something out of this talk. He's a high functioning, would have been called Asperger's before they took that out. And he was telling me that he was thinking about going on different dating sites that are now for gay and bisexual. And he was questioning his own identity. And I realized he was having side effects from medications where he had no libido. He was not getting erections, and he was thinking, what's wrong with me? Maybe this is the wrong body. I'm not attracted to females. And I thought to myself, wow, so many of these people we get have been on medicine for so long that we probably have to factor that in too, because that might confuse them about why aren't they getting urges? Why aren't they in tune with their body? So I just wanted to throw that out real quick, that should be factored in too.
Absolutely. It's a great point. Okay. So trauma has been definitely alluded to throughout. We talked about discrimination earlier. We talked about bullying. Adults with intellectual disabilities are often victims of discrimination simply because they have a disability. We all know that. People with ID who identify as LGBTQ+ face further bullying and harassment simply because of whom they choose to love or how they express their identity. These individuals need support from their caregivers to ensure that they're able to meaningfully access the LGBTQ+ community and develop positive sexual identities. Without encouragement and support from family, friends, and professionals who care for them and about them, their ability to fully express their sexuality can be inhibited. People who identify, who have an intellectual development disability who identify as LGBTQ+ have the same right to express their sexuality as any other neurotypical person. This fundamental right can be undermined when caregivers are unsure of how to discuss sexuality with an adult with ID. Creating environments where LGBTQ+ adults with intellectual and developmental disabilities feel safe to openly discuss their sexuality is challenging for even the most trained provider. Talking about issues that are central to those in the LGBTQ+ community may make caregivers and family members feel uncomfortable because they do not have the knowledge to discuss these issues as in an informed and empathetic manner. So it really, there's a lot of trauma that can happen simply by not being accepted. Again, like I mentioned before, Melissa is very fortunate to have two parents that fully accept her. But she's had experience in the community that she has not been accepted, and she has had challenges with being bullied and discriminated against in other ways. I also want to mention, Jennifer talked about this both in the document and also earlier, but even with providers in trying to get support for Melissa from a mental health perspective regarding, her suicidal ideation and her other anxiety, she has had, unfortunately, a slew of counselors and providers that have discharged her from their services, just indicating she needs more support, but they discharge her to nothing. And to me, that always just, Jen and I have had many conversations over the years of just, I don't understand that. She needs more support, but you're giving her zero support. So, there is definitely a barrier with this population, and that discharge from services for Melissa has likely led to, abandonment. And I know the mother even brought that up in regards to potentially sending her to Sagamore or, a residential school, not wanting her to feel abandoned, that they didn't care or support her. So I definitely think that, providers in this case, unfortunately, have really failed her. It's been hard to find a provider that can both support her exploration of her gender identity and her trans and connect her to the trans community while also supporting her from a social aspect and, within the other symptomology that she has from her anxiety and her suicidal ideation and her aggression. It's likely that it's more than one provider that we need to kind of bring into the picture. Jennifer and I have spent some time just researching providers that take the insurance, that have experience in all the areas. And before even just going in for an intake, having conversations, and Jennifer talked about doing this with the mother, having conversations with the provider saying, this is reality for Melissa right now. This is what we need support with. Can you support her? To avoid having these discharges to nothing when they indicate that she needs a higher level of care. She will go into the hospital. She'll get some short-term treatment for, typically it's for suicidal ideation. And then she's once again discharged with no outpatient support. So, that is very traumatic for anyone to not get the support that you need, but it is traumatic in this population, and for the family as well. So it's important to mention that, you know, where it's a difficult combination of symptomology for someone with an ID, with autism, with, you know, gender, potential gender dysphoria, with PTSD. You know, Melissa has a lot of factors that really will benefit from therapy. We just need to find the right provider that kind of won't give up on her. And I know David had asked about kind of social groups and things like that. And her autism and her ability to connect has gotten in the way of that, like it was described in how she may act in some of those groups or at school or things like that with social media. So it's a very complex situation to gain support. But again, trauma is a really big factor, not only in this case, but in the field, for someone with ID that is exploring their gender identity. You know, like I mentioned earlier, with research numbers, there's a high percentage of physical assaults and sexual assaults on top of what I'm just talking about with bullying and harassment and potential abandonment. So trauma is a very large factor in this population.
Okay, so SAFE was developed because IDD individuals, ASD individuals with intellectual disability clearly need sexual education. It stands for Stop Abuse for Everyone. It was founded in Texas, so it's kind of nice to know something other than gun control was being discussed down there. So I believe it was in Austin. Austin's a lot like San Francisco, so it's not like the rest of Texas. But the point was to explore common misconceptions and then figure out how to help these individuals. And example of misconceptions, and I'll follow up again on Elisa's slide, is that because someone has IDD does not mean they're a kid. Cognitive, emotional limitations or delay does not mean hormonal or biological delay. So they don't seem like they go together, but they do. And people have to understand that in these individuals, they're getting urges, they're getting feelings, they're getting reactions. The hormone levels, if tested, would show that, but it gets missed. And the other purpose of this was to look at the link between these misconceptions, how people are treated, and the result and the experience of violence, because it is all too frequent. And then obviously the point then is to develop some strategies for trauma-informed responses for these individuals, not only to have a preventative purpose, but also then how to help them if violence has occurred. All right, so again, on the misconceptions, people with IDD, whoop, let me go on. Oh, you know what? I have it on my thing too, so I was one behind. There we go. People with IDD are asexual. Obviously, we've talked about that. That's not the case. Asexuality is not more common in people with IDD. Does this come from treating adults with IDD like children? And I believe it does. I think people see them that way, and that's unfortunate. People with IDD can't control their behavior. Well, I think we have to realize people with IDD are not a totally homogeneous class of people. There are many that with education, with therapy, with the experience they can. And then a lot with IDD, just like in a typical population, may have OCD with compulsive habits. They may have Tourette's with unavoidable impulses. So that's maybe where it's coming more from the comorbidity of these psychiatric diagnoses than simply, hey, I have IDD, so I'm going to do whatever I want when I please because I can't control myself, because that's not always the case. And I think there's a lot of stigma and discomfort in thinking of them being sexually active, and there's not proper education and guidance, so they may explore it in an inappropriate setting or with inappropriate people. And the lack of privacy may force the individual into exploring sexuality in an unsafe place. And, and I just wanted to give an example, a little graphic, but I had a guy in my practice with mild ID and autism. And the parents, nobody, the school, nobody ever taught him about masturbatory practices. And he ended up in the emergency room because of doing things that were unsafe. He didn't know what he was doing. He had skin burns. And I realized from that point moving forward, that's my job as the doctor, it's the job of the therapist, the job of the parents, if they're comfortable, the school, to try to guide people and to educate them properly. And I also have a couple I treat that are both mild to moderate ID. They got married, they're living in an apartment, and nobody has ever spoken to them about anything from hand holding, sleeping together, what's an erection, what's sex, what's safe sex. So when I do these so-called medication management sessions, it's really all about that. It's so important for us to do that with these individuals, because they're going to get into trouble without it. And it's not fair. They don't understand the whole process, but they have the urges and they have the right in the positive flow of their life to be able to experience that and enjoy that. All right, now limiting independence is thought by some people to protect from abuse, right? Let's keep them safe. Let's keep them away from the danger. Because those with disabilities are at higher risk for abuse and assault. And the research that I saw was about 5 times more likely, but I'm sure you look at different cases at different researchers, the numbers vary, but clearly there's higher risk. There's less understanding and reading of social situations. But the thing that we really have to point out, and I think that SAFE program points out, the typical stranger danger is not overly effective. And why is it not? Because a lot of these individuals are in our group homes. A lot of these individuals are in the homes with their moms and dads. They're home with an uncle or aunt watching them, or a ComHab worker coming to get them. And estimates are over 97% of abusers are known and trusted. So while yes, we want them to learn, don't just trust any stranger, a lot of them, that's not really where it's happening. And frankly, community integration and learning to have trusting, healthy relationships and being able to go out into a store, meet other people is all valuable. So I think it's just a different way of looking at it. And I thought that was very good that the SAFE program addresses that. Now, as far as sex education and promiscuity, you're going to hear a lot about that again in the political culture. Oh, no, leave it to mom and dad, leave it to mom and dad. We shouldn't be teaching it. But again, the statistics don't really bear that out. There tends to be a delay in sexual activity. There tends to be a reduction of frequency of intercourse, reduction in partners, increase in safer sex with condoms. Information needs to be based upon biological needs and adapted to functional needs. So it's not a one-size-fits-all education program. Like I said in those case examples, what level are they at cognitively and emotionally, and slowly give them the information that they need. Now, the next bullet point was interesting to me when I read it. I hadn't thought about it, but they found that they did better in non-segregated groups. They found that it gave individuals a better understanding of the opposite sex, some role models, which I think Elise brought up earlier, role models being important, trans, male, female. But the big point was that if you're going to do this in a group format, you still have to have access to an individual, private, safe place to bring up, especially if there's someone of the opposite sex, they might feel uncomfortable. But I thought this laid it out kind of nicely about how to address them at their level, meet them where their needs are, and to not isolate, because isolate doesn't equal protection. It really just means isolating. That's it.
So there are definitely some therapeutic interventions in regards to supporting this population. So going off of what Dr. Kent just shared about sexuality education is really an important one. And like Dr. Kent stated, oftentimes systems and family members and providers are shy away from that with this population because they think it may just open up the door for promiscuity or more sexual behaviors, when in actuality it's the opposite. A lot of times they're exploring because they don't understand. The other piece too is that sexuality education really should include that, unicorn, that gender identity unicorn, helping them understand that, there is a continuum, who they may be interacting with, things like that. Social skill practice is incredibly important for individuals that are questioning their identity and also have an IDD diagnosis. We touched on that even before we started the training. Having an accurate and supportive an appropriate method of communicating is very important. Going back to Melissa, some of her difficulty in social environments and social communication has led to bullying and her inability to connect. So that is just as important in order to build those connections so that she can have these interactions. Within this slide, there are two books that are recommended for the population, for providers that support the population, that are positive LGBTQ themed novels, depending on somebody's cognitive level and ability to take in this information. They can also be used directly with the individuals. Being part of a training like this is a really important therapeutic intervention. You're familiarizing yourself, you're able to then pass on this information and support other staff with gender dysphoria. Again, having a gender identity and questioning your gender identity is not solely a DSM-5 diagnosis. The dysphoria piece is important, the distress. There are people that we all have encountered that feel really good about it. There may be bullying, there may be stress in regards to getting services, but the actual act of their gender identity and coming out as trans or non-binary or whatever they're choosing is not causing distress. So they would not qualify for a gender dysphoria diagnosis according to the DSM-5. And a lot of times we encounter people in the field that feel that anyone that is choosing to change their gender, unfortunately, has a mental health diagnosis, and that's just not the case. So familiarizing and training and getting support and building your capacity and working with the population is a very important therapeutic intervention. Use of cognitive behavioral strategies is incredibly important. This helps to identify coping skills. Melissa has been exposed to a lot of CBT interventions. She has shared them with her sister in the midst of her sister's crisis. So like Jennifer said, we know that she is taking them in, which is wonderful. But we need that to continue, especially in this case, but in all of our cases. And that's where, finding the right therapist really is an important factor in Melissa's case. Identifying social support networks, incredibly important. I know this question came up prior to us starting the training as well as to what Melissa has. She has started some groups, which is amazing. And we want to continue to build upon that for her. Using gender neutral, non-heteronormative language. So it's important to use the language that they prefer. You see it more now just in general of people indicating their preferred pronouns. You see it on social media. You see it, I've even seen it on Zoom. People will join with, in parentheses, she, her pronouns or whatever they are choosing. So just in the neurotypical population, we are seeing this more publicly. But again, with this population, the fact that Melissa has identified as female, she wants she and her pronouns. She has indicated that, and those around her are using it. I know Jennifer mentioned that at times the mother will slip up, but again, it's not due to lack of respect of this. It's just getting used to it, and she will correct herself. And I think that's very important for Melissa to see. We have a couple of other individuals in START that have indicated to their team and their system of support, a preferred use of pronouns. And we have spent some time educating on utilizing those. When those are not utilized, it can definitely impact relationships. It could impact trust. They may not feel accepted and supported, and that could lead to more distress than they would normally have to deal with. And then again, utilizing individuals' preferred pronouns and name, regardless of personal feelings. So there are people that, do feel a different way than we've presented today, and they have every right to their own personal feelings. But again, when we're in this field, when we're working with the individuals, our personal feelings should not play a role. And we need to utilize their preferred pronouns and name, help them feel supported and accepted within that environment. It goes along with too. I know that, when I was younger in the field and I worked in a group home, I worked with some people that didn't, believe in medication. And they would make that known and make the individual almost feel negative because they were on medication. Our personal feelings about whether it be medication or their preferred pronouns really don't matter as paid supports. We need to be respectful of their preferences. So this slide is all just local resources that I have researched. There are quite a few. The unfortunate part is that there are not many that overlap in IDD and gender identity. So on the left side, we do have the LGBT network, which is Long Island based. There is health and support, there's testing and education, advocacy in the field. There are school programs, which were really wonderful. There's also workplace programs to assist individuals that are questioning their sexuality, have job coaching and job support. The Transgender Resource Center. So this program and organization also assists with vital record assistance. So someone that is trying to change their gender within their birth certificates and other legal forms, they provide assistance in doing so and direction. That should say support groups. There are workshops and educational programs within the Transgender Resource Center. There's also assistance in locating friendly doctors and healthcare, which is really important. If you walk into a doctor's office that does not respect your gender identity, you're not going to feel connected and wanting to be supported by that professional. So they have a resource center that you can kind of look based on where you live, what support you're looking for, and knowing that those doctors are going to be open and supportive to your gender identity. There's also housing assistance, some training and community events. They have some guest speakers. Pride for Youth is also local. They provide services for the LGBTQ population from young people through age 45. They have a coffee house, they have community education. They also provide counseling services and support groups. They're in both Nassau and Suffolk County. On the right column, unfortunately, it's a bit shorter, but these are the first two are programs that do specialize in our population. So Healthy Choices, Improve Relationships, Healthy Life is run by Pam Boyle. She's a socialization and sexuality specialist. She does individual and group sessions, and she specializes in gender identity with the IDD population. Unfortunately, we recently learned that she no longer takes Medicaid, which really impacts the support. So she specializes in our population, but that very much limits the ability to support the population. We are exploring or trying to explore with her if she would work with budgets and brokers and such to get reimbursed, and through private pay in that way, which I would hope she would be able to work with. She does take private insurance for the younger population that are still on their parents' insurances, but this does significantly limit the ability to serve the population, unfortunately. We just learned that within the last week or two. And Free Family Residence and Essential Enterprises has Free to Be, which is our LGBTQ advocacy group. They also do socialization groups and kind of bring them to the individuals together, again, specializing in the IDD population and gender identity. And then I've listed 3 hotlines for young people in distress, all related to gender. So the Trevor Project, the Transgender Suicide Prevention Line, which is run by transgender volunteers. So this is a really great resource. And then Pride for Youth has their own hotline for 24/7 support as well. And that is it. I'm going to unshare and bring it back to the group to see if there are any questions, comments, recommendations from Melissa. I think we're all pros now. We can support this population. We need to make a clinic that works for the IDD and gender identity. Are there any recommendations that can be offered to Jennifer to bring back to the system for Melissa?
I don't have any recommendations, but I really, really enjoyed the presentation. I think that you guys touched on a lot. Something that I always mention, and I know that we do mention this a lot, but the neurodiversity with the interactions that these people are having, and that Melissa is also diagnosed with autism, and there could be a lot of perceived negative interactions that are neutral. I think that's just something else to just consider when we're interacting with people that are on the autism spectrum, that they may be perceiving neutral interactions as negative too. So if there is an extra, negative connotation behind it, or if they're kind of perceiving that their supports are not accepting them, I think that's really like another barrier to care to consider. But I think that you guys touched on so much, even just like, having a pool of doctors that are accepting of people, that just removes another level of anxiety. And I think that that's going to be really helpful. Unfortunately, I don't have any recommendations, but if I end up coming across something that I think would be useful, I'll definitely let you guys know.
Thanks, Lisa.
Thank you guys.
I'm just curious, because it's been so difficult to find a therapist and someone to support Melissa, but because of what they state is her suicidal ideation, with transgender and people who are struggling with their gender identity, based on this presentation, a lot of them have these kind of thoughts and these feelings. So I don't understand why they wouldn't be more able to support someone going through that.
I recently spoke with the supervisor at the school where Melissa attends, because they did have programs, groups, but apparently Melissa's schedule doesn't work well, and they're going to try and start a group or include Melissa in a group earlier in the day, doesn't clash with her schedule, and hopefully that might be successful for her.
It's great. Thank you.
It's just, something.
Yeah, absolutely.
I just also wanted to make a point. I think he jumped off. He had to leave a few minutes ago, but it was the director of special education. He, at the beginning of our CSE meeting, he actually made a comment and said, "What pronouns are we using today?" And the mom said, "We're using she, her." No, I think it was they, them pronouns that day. So the rest of the meeting, everybody was using, to the best of their ability or memory, to use they, them pronouns. And I thought that was really amazing. And I feel like that's something, if there's any gender identity concerns or confusion or whatever it may be, that's something that should be done at the beginning of meetings, just to make sure that the person's being respected as well.
Absolutely. We have an individual through START that comes to the resource center fairly often. And every morning, we kind of talk to staff about asking, what pronouns do you prefer today? Because there was variability amongst the continuum that we talked about earlier. So I think that's amazing that the director of special ed did that. And that is probably really helpful to Melissa to feel accepted and supported in her CSE meeting. What's been really difficult, I think, for I know ACA works with her and START, and Yvonne in her role with this case has been the lack of ability to find like a singular provider, or even a few providers that can support Melissa in all the different areas. So, we've had providers that can't work with the autism or the cognitive deficits, but could deal with the gender and the suicidal ideation, or isn't adept at working with the suicide ideation or the gender or one or the other, but can with autism. And we haven't been able to find kind of that one provider that can support in all areas. So I think that's been really impactful to this case. And luckily, she's still young and on her parents' insurance, so she's not solely dependent on Medicaid, because our hope is that we can find a private therapist that can and is willing to work with us. And when things do get hard and maybe the suicide ideation is stronger, not just discharging her and saying, I can't support her and sending her off into the community, but calling the crisis line and utilizing care management and utilizing the supports that she has in place to ensure that she's adequately supported and can continue her therapeutic services. So that's been a really large stressor and a large focus in this system.
The biggest problem Mum has, which she talks to me about constantly, is that Melissa is entitled, I think, to 10 hours a week of respite and 16 hours a week of ComHab.
Yep.
And she doesn't have a worker for either.
Yeah.
Now the holidays are coming up, and I don't know what Mum is going to do with Melissa home all day, every day.
Yep.
And apparently across the board, there's just no workers.
Yeah, the staffing is very difficult.
It's a huge problem. One of the biggest areas that we find impacted is ComHab is the number one of the lack of staffing. We
Yep.
just can't get staff. And
Right.
that's been a huge issue. And I just wanted to say, you know, to New York Start, thank you so much for doing this presentation, because when we first got Melissa, I think we were just high anxiety for months because, you know, where to turn between the IDD and the gender identity issues, and not to minimize Lieber's at all, because she doesn't just have Lieber's hereditary optic neuropathy, she has Lieber's hereditary optic neuropathy plus, which is even rarer.
Right.
And there are very few people out there who've even heard of it and know what that means. And the vision loss can be very sudden, as I'm sorry to hear she has suddenly had in one eye. Trying to get somebody who can support all that is really pretty much impossible. But you got to start with some education. So this is incredibly helpful. And I'm so glad to hear that, you know, she has gotten some people to support her and help her. And I think it's amazing what the director of special ed did, asking about the pronouns. But yeah, I mean, for me in care management, Melissa was a bit of a, I don't want to brush it off, but the likelihood of having another individual with this constellation of issues is pretty small. But one of the things that I find is a huge issue is sex education. There's like nobody to send people to beyond Pam Boyle. I don't know anybody to send people to. And I just wish that in this world, we had more access to sex education for our individuals. There's a crying need for it.
I absolutely agree.
But you know what, it's sad, it is good to have specialists, but the primary people need to be able to do it too. You know, to again, not to that degree. It kind of reminds me like in rural parts of the country where they need to train family practitioners to handle depression, anxiety, because they don't have psychiatrists and all that stuff. So both need to happen. I don't know why local therapists, pediatricians, family doc need to be more involved in this whole process. It's just not educated on it enough.
They're not at all. I mean,
No.
the conversations I've had, you know, the conversation I had with the 75-year-old little Sicilian grandmother as to why her granddaughter should be allowed to look at porn. You know, these are not conversations that I certainly wasn't trained as to how to manage these sort of conversations. They're just such a crying need.
Yeah.
I just want to go back to something Esther said about the chairperson from the CSE meeting. The other thing he did, which I've never heard of, is he requested a psychiatric eval to be done when Melissa was calm and not in crisis. And it's been done. And I don't know if you've got a copy of it, Jennifer. I did get a copy of it. Mum was quite upset with some of the things that were said in there about the description of Mel. But it was very good. It was very good. And I've never had a CSE chair do that when a kid requests it at their cost when a kid is not in crisis.
Yeah.
Good.
Yeah, that's wonderful.
Yeah.
David, I know you had unmuted a few minutes ago. Did you have something you wanted to add?
Yeah, actually, it's just in regards to people that can work with her. Actually, I know a practice that can work with her. Sadly, they only work with private insurance. I put in a chat for everybody. It's called Better Life Associates. They have around 8 to 9 psychologists who are specialized in this population and also in trauma. I'm finalizing the agreement between New York Start and them, but sadly, they only have in Port Washington and Oyster Bay, their offices, but they're open to Zoom meetings. So maybe one of the psychologists in that practice can be the support, but you know, they only work with private insurances. So that's only the downside. But the one of the psychologists there is specialized in this population. They also specialize in trauma. So it can be a point of contact that, you know, can support her. So I just want to put that out there.
Thank you so much, David. That's wonderful. Okay. So, I know that I feel like a lot of things that we talked about is already been in progress because the system around Melissa has been so invested in finding support. I'm hopeful that some of the local resources I shared could be helpful. I'm sure having Melissa, giving her access to some of those hotlines could be very helpful as well. We definitely can look at Better Life Associates for Melissa, add that to our list, Jen, of the ones you guys are contacting. And again, I think this just brought up the need for, further education and training. And by doing this topic, everyone here has an increased capacity in supporting individuals similar to Mel. But I agree, Esther, we're probably not going to find someone that has the constellation of Mel ever again, but pieces of it for sure. So, again, the system surrounding Mel definitely have really bounded together to support her, continuing to find that provider that won't give up, that can, address the trauma along with the social side of things, as well as helping her explore her gender identity amongst that continuum. Since she has, fluctuated a little bit, there's still some exploration that it looks like she's doing, while also providing, I know Yvonne, your main support for the family, and that's amazing. So continuing to provide that. And now hopefully you have an increased confidence in working with this side of Mel's, or Melissa's, excuse me, constellation of
Definitely.
diagnoses and supports that are needed. And I know that Jennifer, you have supported the family along with care management, and Yvonne in learning more about Mel and kind of how to support her underlying vulnerabilities that lead her to crisis. So again, I don't know if we came up with anything brand new, but I think there's some new resources. And again, a big part of this was just education for our
Yes.
community.
Thank you. It was very, very informative. And it's funny with Mum, I don't know if she's lost a lot of workers, but every time I meet with her, she keeps saying to me, how long have I got you for? And I'm like, you've got me for as long as you need me. I'm a lifer, don't worry about it. Because she keeps thinking I'm going to close and leave. And I'm like, no. You've got me until I retire, put it that way. So she was quite happy with that.
Good. That's wonderful.
It's been a wonderful training. Thank you.
You're very welcome, Yvonne. Thank you so much for joining us.
My
As
pleasure.
I mentioned earlier, I did record this. This is not one that I'm going to put up on our YouTube channel as we put others up, just because of the topic, but we can share the link. So, if Esther with ACA, you would like someone to watch this, feel free to reach out. We can share the link with you. I know Sean had asked about that earlier. We'll funnel that to Shirley, if that's okay with you, Shirley. And I'll make sure that she has the link and she can provide that to anyone that requests it, to expand the knowledge of those around us. I think that's the best thing that we can do in this field is to continue training.
Thank you so much.
You're very welcome. Thank you all for joining us today, and we'll see you next time.
Thank you.
Thank you.
Bye.
Okay.